So I'm Chris Bryan. I'm the VP of IT and Public Policy at Clarity. So technology is something that is near and dear to my heart. We talked a little bit about it in the previous panel. I did want to let you know that I knew a lot of people would not sign up for technology because I always say, even for grants and development at Clarity, technology's not sexy. Nobody wants to talk about it. So while everybody else is going to talk about fun stuff, nerds, what do? They bring ducks. So if you guys answer the questions, when I offer them to you, you could walk out with a duck today, okay? All right, who's excited about that? Okay, see, we can have our own fun. Okay, so the key topics today I want to talk about. So it's going to seem a little dry and you're going to go, when are we getting to the point? It's really important that I talk you through some of the historical contexts of mental health and mental health funding before I jump into the health technology landscape, right? So you guys can get the layer of that. And then we're going to talk about the Senator Menendez Senate Bill 640, which is really important to this conversation, and then where we're at today and what we need to do. So first, a little background, lots of words. You guys are going to get these slides, and I'm less concerned that you know the details, except to say, really quick, I'm going to breeze through these. So in 2003, the Bush administration did the New Freedom Commission. That was really the first time this whole wave of mental health really got going. And that was, we need to do more in our communities. We need to figure out anti-stigma. We have to do education. We've got to try to figure out how we're going to start incorporating this into health. Followed by 2011, Texas put together an 1115 waiver, and you don't have to know the details of that, but they had determined that they were going to fund innovative projects. $29 billion was put out for these innovative projects, and behavioral health was a priority population. So that's really when we started to jump into this thing whole hog. 2013, the Texas legislature makes their very first big increase in mental health funding. We were getting incremental stuff, but this was like the first real big push that we got. From that, the Senator Jane Nelson at the time said, you know what I'm starting to figure out? She was the head of finance, and she said, I'm giving mental health money in jails, and I'm giving mental health money to schools, and I'm giving mental health money to police, and I'm giving mental health money. I don't know how much I'm giving. So she asked that we do the statewide behavioral health coordinating council, and that was exactly that. It was all the state agencies sort of got together, and they built our first statewide mental health strategic plan. So now we at least have a sense of where all the funding is and what's happening with it, okay? And then I just got done talking about this. 2016, Speaker Strauss, in the interim, he created the Select Committee on Mental Health. And that was really transformative because that's all we talked about for a spring and a summer. And it really laid out a lot of the changes that we were able to make that legislative session. The recommendations were, we've got to really get serious about integrated health. We've got to really get serious about early prevention and parity. Okay, who knows what parity is? Come on, yell it.
Having the same coverage for behavioral health issues as you have for physical.
Look at that. Even Steven, mental health is not even Steven. And while parity really relates to the coverage on insurance, we now also use that to talk about other things because there is still such a huge gap. And so, mental health parity, federal was passed in 2008 and expanded again in the Affordable Care Act. And Texas passed HB 10 following the Select Committee on Mental Health in 2017. And parity really, truly is around insurance coverage. And if you're going to cover something in physical health, you should cover something similar in mental health. Okay. Questions on parity? Okay. So what I did was I built this timeline. So everything that we just talked about, except for these two, in 2019, we made major upgrades to our state hospitals. They've been around forever and ever and ever, and they pulled money out of the rainy day fund, the legislature did, to do state hospital upgrades. And then last session, we got $2 billion to build new state hospitals. So what's the trend you guys see here?
Institutionalization.
Well, that may be true, but that's not what I'm going for.
Awareness.
Awareness is going on. What else? Yes, 100%. So look at all the funding that's happening since 2003. It's increasing because remember, I told you how much this is. We've got the big thing here. We know where all the money's going. So, parallel universe. That was mental health. Let's start talking about healthcare technology. So, the HITECH Act of 2009. The government loves abbreviations. So HITECH stands for this whole crazy thing, but nobody ever cares. So for our purposes, we're just going to call it the HITECH Act, okay? It was during the Obama administration, and you may remember in 2009, that's when we had the bad crash, and they put the American Recovery and Reinvestment Act and put a lot of money out there for a whole lot of things. This was part of it. And the HITECH Act, what it did was it had a bucket of money to provide incentive payments for providers and hospitals to start using electronic medical records because the adoption was low, people weren't using them, technology is expensive, and so they had this thing that is certified electronic health record, and the term certified is important down the road, so remember that. And the certification was, you can't have just any electronic health record. You have to have these items in it, and then we'll go ahead and pay you as a provider or a hospital incentive money to help you overcome some of those implementation costs. All right, the caveat to this was this only went on for 5-6 years, the incentives. And if you did not get on, then you were going to get a penalty. You would be penalized by the federal government for your payments. So clearly everybody's like, I'm going to take the money, I'm going to get on because I don't want this, right? Simple, basic, HITECH Act stuff. Unfortunately, behavioral health was explicitly and directly excluded because adding behavioral health was going to make the bill too big for the federal government. So they just drew the line and said, we're going to do it for this. We are not going to do it for this. What's an issue here? What does this tell you right away? What did we just talk about? No parity. How is that not parity? How can we exclude a whole part of the health sector, right? Okay, so that was 2009. In 2016, the Cures Act comes out. And there's a ton of stuff in the Cures Act. But for our purposes today, the Cures Act said, you know what? Everybody has an electronic medical record, so now we're going to focus on getting everybody interoperable. What's interoperability mean?
Everyone can talk to each other.
Everyone gets to talk to each other electronically, of course. So the assumption here is that everybody has digital health medical records, and so now the federal government wants to make sure you're going to get interoperable. What's the problem there? Well, that's true, and that's what this is actually supposed to be. So they're saying, remember when I said certified technology? You would have been interoperable if you got the right technology. Just nobody did it. Now they have to do it. If I ask you the question and say, are you interoperable? And you say no, does that mean you're not interoperable? Or you're in behavioral health, you don't have an electronic medical record? Don't know. So then the next thing that came out of the Cures Act, this just went final a couple of years ago. How many of you guys use a patient portal or an app on your phone for your medical? Yeah, all of y'all. So now the Cures Act says that you are required to have and offer a patient accessibility portal to their health information. So now we're even further down the line, right? The problem is, what if you don't have an electronic medical record? So now behavioral health is excluded. So on our timeline, I put the technology pieces in black. So here we are. The assumption is that all of this stuff has been going on while all of this stuff has been going on. And where's the funding for the behavioral health technology? Bam! We don't even know. Who has it? Who has an EMR? I don't know. We don't know. Enter the Senator Menendez bill. We went to his office and said, look, we've got some problems because we've seen this history before. And history tells us that pretty soon we're going to get incentivized for this, but then it's going to move to a penalty. We've seen this history before, right? But we don't know. We don't know what we don't know. We don't know. So this bill was set up to conduct a study. That's all it was to get out and survey behavioral health providers. Local mental health authorities. Who knows what a local mental health authority is? Tell me.
It's the state that, well, it's a quasi-governmental entity made up of counties and state, and they have a performance contract that dictates the level of services they have to provide.
Well, that was quite the definition that I wasn't expecting, and you get to share a deck with someone. Christine, give another one.
They are like a huge provider of crisis services, among others, like in the 98 system, and help. Yeah. What she said.
Yeah.
She said it's all in common.
Yeah, so ultimately, they are the community mental health providers, right? So on the medical side, there's a federally qualified medical health center, and then the local mental health authority is the agency from the state sends the money down for mental health services, okay? So the study was for state hospitals, local mental health authorities, hospitals, and provider groups. And really, we wanted to try to get a look at the Medicaid providers, right? Because that's what we have more control over. So the questions were, do you have an EMR and do you use it? How well do you use it? Do you connect to other providers? What type of information are you sharing? Do you find value in using digital health? And what are the barriers to implementation? So the survey went out, and the findings were state hospitals and local mental health authorities had EMRs, but they were actually sharing by email and fax. So they got the incentive money and they got their EMR. Actually, they didn't get incentive money. They got the money from the state to help them purchase their EMRs. But they're just using it. So they're using it internally. That's all they're using it for. They are not interoperable. We also found that most freestanding psych hospitals don't even have one. Why do you think that most freestanding hospitals do not have one? What was the number one barrier? Too expensive. If you're in mental health, and I say this all the time, especially running tech at my hospital, mental health is very
very low margin. I always say nobody's getting rich in mental health. We're all in this work because something drew us to it, there's a passion to it. We want to take care of something, fix something. And so it's very cost prohibitive. They came out and said, not only do I have to buy an EMR, I've got to now train my staff, which means they're not doing something else they should be doing. My billing is going to get interrupted. And so without any incentive and without anybody telling them that it's been required, they've just slowly and surely been moving forward. So now they're 15 years behind the power curve on digital healthcare. Any questions on that? Comments, thoughts before I move on?
I was just gonna say, like, individual providers would have even more of a cost barrier if the, for-profit hospitals are finding it to be prohibitive than something
Correct.
that's, that a part-time private practice is gonna be like, can't do it.
That is a great point. And let me tell you another thing that was super interesting. While the freestanding hospitals didn't have one, if you were a psych department in a major hospital system, you did, because you were using one of, a section of one of the big ones, because they got the incentive money to go ahead and put in their technology. Comment, Ann? Yeah.
Well, so, and this might be off, and if it is, we can just, is there, as this group, and
Yes.
it made mental health, so I come from the perspective of a person with lived experience. And having experienced within my own family members discrimination or difference in treatment because somebody found out they had a mental health diagnosis, was there ever a consideration of the person whose information it is being able to still determine what gets shared and what doesn't get shared?
So that's a great question, and I'll go ahead and take it now before we sort of jump into the rest. So part of the certification mandates are that you have to abide by the sharing rules, and there's a couple of protections. So one of them is, who knows what a health information exchange is?
It's a place where you can upload or download documents from provider to provider for trying to promote continuity of care.
Perfect. I'm getting my microphone stolen. So I always explain it, that's exactly right. I always explain it to non-tech folks that if your computer is your telephone, the health information exchange is AT&T, right? That's how it's moving around.
from provider to hospital, et cetera. So we call them HIEs because Health Information Exchange is a lot. So one of the rules is that a patient can opt out of sharing from an HIE. So if you go to your provider and you get your here's your rules, one of them is we are sharing on a health information exchange and you can opt out. So the EMR has the ability to take you out or put you back in, okay? The second thing is they have to do what's called segmentation. And so certain items are segmented from sharing. Does that make sense?
Yes, can the person determine that, or is it?
That is the point of you being able to opt out of your health information exchange. If you don't want to share your information from provider to provider, then the provider you go to, you need to say, I want to opt out. And you can always opt back in later. Just understand that when you're at other providers, then there's certain pieces that they're not going to be able to see. So that's all a personal decision.
And that's what I was wondering, so if you say no, you're globally saying no, it's like, what if I just wanted this doctor to be able to see that, but not this doctor?
So that's actually taken care of at the HIE level. So as soon as a patient comes to me at Clarity with a little form saying, I understand that I am revoking, Texas is an opt-in state, okay? Not all of them are, but Texas is opt-in. That means as soon as your information goes in the EMR, it's going to go out, okay? So you have to opt out. All right, and what ends up happening is all I'm doing is I'm sending the Health Information Exchange a little box that says, this patient wants this information protected. So anybody that goes and tries to get it from the Health Information Exchange, that information is segmented. Does that make sense? Make sense? Clayton?
Last I checked, our HIE wasn't very functional.
Wasn't very functional?
Like it didn't connect so much, and not many EMRs or hospital systems were really.
And you guys are on the ICC, I think? I don't know that much about y'all's Health Information Exchange. So I'll have to get with you after that. Yeah, on the healthcare side. We have because ours is, we can talk about Health Information Exchange at the Q&A. There's some issues there too. But let's move on from here. But Clayton, I'll talk with you about that. Okay, so cost. Again, I mentioned the cost prohibition for technology. This is a little dated. I'm hoping Milliman gives us another one soon. We included this in the state parity report, that even though mental health reimbursement is getting better, it's still incredibly lagging behind medical, right? So here's the Medicare allowed expense, and we're still under it. And to that point, I've just recently run some data at Clarity, and if we have a child come inpatient, we will lose 9% on Medicaid, and we will lose 18% on commercial insurance. So we are clearly below this line. Okay? Questions on that?
So the whole conversation about parity and that the bills were passed was that, okay, it's done. And that never showed up in reality. Was there no enforceability? What is the barrier? What?
Fantastic question and perfect timing. Yes, there's some issues with enforcement. There was also some issues with very specific definitions on how to enforce it. And the Biden-Harris administration just a few weeks ago add more reinforcements around the parity rule. So now it's going to also include rate reimbursement. It's going to count prior authorizations, because we know prior auths are much higher in mental health than they are in physical health. It's going to count out-of-network providers, because we know that's also much higher in mental health than in physical health. And the one I love the most is if you deny services, there will now have to be a report as to what the reason for denials were, so they can start trending it. So more on that to come, because that is right around the corner. Great question. Okay, so now I've thrown on the SB 640 survey here, and that's great, right? That's great for us. We know where we stand. We know we're super far behind. And so now what are we going to do? But wait, there's a twist. Because it's Texas, there's always a twist. So I happened to be at a conference in Dallas, and I made an emergency call to one Alexandra Cav and said, oh, crap, we've got a problem. Enter Atlas. And again, what did I say? The government loves their acronyms, and it stands for Aligning Technology by Linking blah, 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 blah. So the state of Texas added this little magic thing we're about to talk about to their supplemental payment program. Who knows what a supplemental payment program is? Clayton does. He doesn't have a duck. Go, Clayton.
Part of the 1115 waiver allows for there's many different flavors of supplemental payments. Some are for physicians, most are for hospitals, which is another issue, and basically cover differences in what the cost of care is and what they actually get paid.
Correct. Based on what I just got done telling you all, we are not covering our costs. So whatever anybody tells you that we're like raking it in, we are not. And the supplemental payment, go ahead.
I have a question.
Yeah.
So, so that would apply to like tests outside of like the general wellness exam, or?
It really depends. So the supplemental payment programs are designed to help you overcome your cost. So if you are on Medicaid and you come and see me for something and I don't cover my costs, at the end of the year, I'm gonna put all of that information into the state, and the state has these supplemental payment programs to help me overcome some of that cost loss. Does that make sense? It's for the provider, it's for the hospitals, correct. Because what ends up happening, you guys have seen it, you get your bills and it says, it cost $20, but we paid your provider $1.60. We've all seen that, right? And so what ends up happening is these supplemental payment programs help the providers to overcome some of that cost loss. Okay, any questions on that before I go on? Okay, so the state of Texas, HHSC, says, you know what, we have got to make sure that we are in compliance with the CURE Act, and we need to make sure that our folks are interoperable. So I just filled out my Atlas questions 2 weeks ago, and this is what it says. Does your organization connect to an HIE? Does your organization send information back and forth? And if not, why? But again, you gotta hope that some people are honest here and they're gonna go, because I don't have an EMR. I just don't have one. The state is trying to get us here, and behavioral health is behind. So, today, it's what they call a structured measure. It's just a measure, they just want the information. But we know how this thing goes, don't we? We know how this thing goes. So I called Alexandra and I was like, uh-oh, where we were trying to think we were ahead of the 8 ball, it seems now we're in a pre-crisis mode for behavioral health. This is another little twist in this story. So, separate of freestanding hospitals not having EMRs, remember I told you the local mental health authorities do, okay? So today, they get certified by the federal government to make sure that they follow all of these items and that they get a certification to be a certified behavioral health center. They get federal dollars for that. And one of the requirements to be certified is that you have to be interoperable, I should say, to a health information exchange. I've also included the Texas Health Services Authority on here. The Texas Health Services Authority is the group in Texas that tries to pull all of this together. It's a quasi-governmental group that is appointed by the governor to make sure that all of this stuff is linking together.
So when you're talking about that certificate, are you talking about CCBHCs?
Yes. So one of the requirements for a CCBHC to get the federal dollars is they've got to be interoperable. However, in order to get their state funding, they have to feed into HHSC. And HHSC's system, the Community Mental Health Behavioral Health System, was written internally, so it is not certified. It's been around since 2008, 2009. It's quite the big, as we say in technology, legacy system. And they still have to batch things up to this system every day. So now they're stuck because in order for them to get the state money, they have to do this. And in order to get the federal dollars, they have to do this. And of course, they get all their information from here. There's nothing here. So I put this big warning out because if anybody from HHSC was here, in full transparency, I happen to sit on the eHealth Advisory, the State eHealth Advisory Committee. So I wanted to make sure this is just a very simplistic stick diagram. There's about 8,000 levels of other complexity here, but just to give you guys the overview for today. So, thoughts, comments?
So the CCPHCs, that is actually a voluntary designation?
They can go for it. However, the state of Texas, the local mental health authorities have decided that all of them.
The state decided all of them would be CCPHCs, not the local mental health.
I think they came together as a group to do it because financially it doesn't make sense not to.
The only reason I'm bringing it up is because federal CCPHC funds do not fund in to Texas through the state. They're done by individual contracts with the LMHS.
That is correct.
Because Texas wasn't in a position to do that.
Correct. There's all these complexities, which is why I go back to my big red warning again. Okay, are we good on this? All right, we're moving on. See, tech is fun, right? Okay, so what should we do? All right, so here's the recommendations that we are working on. We need to make sure that the LMHAs connect to an HIE or to THSA, and they actively start sharing patient information. That is not occurring today. And by the way, why should it? Right? If I'm the IT people at the local mental health authority and I have to do what I have to do, I get my money, federal money, because I'm interoperable, and I'm batching up to the state, so I'm doing everything I need to do to maximize the money I'm getting. Nothing is telling me that I need to actively share. And that probably costs them money that, again, a local mental health authority probably doesn't have. Everybody with me on that? Okay. Develop a one-time grant for freestanding psych hospitals similar to the incentive payment program that everybody missed out on. I will tell you, Senator Menendez did have a bill for that last session, and it failed. And the comment on that was, we really don't like the idea of just handing money to a hospital. Okay, but we got left behind. And so somebody somewhere is going to have to help us figure that out, especially at the rates that the state is paying us, right? HHSC probably needs to start developing a timeline to be using a certified interoperable system if they want to keep talking to everybody else. That's a problem because that's also a heavy lift and expensive. But these are, well, all I'm saying is it's probably time to have some of those hard conversations, right? So for our information, we probably want to make sure, last session, the state hospitals did receive $39 million to upgrade their technology. It was in it was a rider in SB 30. So maybe we need to figure out, have somebody tell us how it got spent. What did they spend it on, and how much of that went to interoperability? And then probably we should request the latest Atlas statistics, since I just filled it out a couple weeks ago. Hopefully we should be able to get that. We should ask for that before session starts. Because again, a lot of this has to do with the landscape. If we have the data, then maybe we can go to the legislature and say this is a problem. Okay. This is a very famous quote. Statewide integration and parity between behavioral health, physical health will be difficult to achieve with disparate clinical data platforms and decision-making tools, said by the most famous one, Chris Bryant. Okay, just some resources. The eHealth Advisory Committee report of 23, when you guys get the slides, these are actually links. And I want you to know there's a new one getting ready to drop December 1st that does talk about some of the stuff that we talked about today. You can go out to THSA or you can email me directly. So that is technology in behavioral health. What did we learn today, kids?
True.
There's disincentives to be interconnected.
Correct.
But we made a lot of progress recently. We're getting there.
We are getting there. We gotta get there a little faster before our providers get penalized. What else? Anything?
Behavioral health is still something nobody wants to see if they don't have to. Even with this sense that, you know, everybody's talking about it, famous people are talking about it, there's my experience of it, we've been lulled into believing that it's okay to talk about mental health issues. That discrimination and oppression is still as much as it ever was. I don't use the word stigma because it tends to soften the blow of what it is. And that's one of my concerns, is that this is more of that.
I would agree with that statement. I would agree with the statement kind of going back to parity is more than coverage issues. And hopefully, if you don't take anything out of this, I really want you to take out of the fact that we have to start looking at mental health through a parity lens on everything. Questions?
So I do have a question. One of the things under CCBHC is they have partners who build their own Medicaid, but they can also have what are called collaborating DCOs. I just went blank. The designated collaborating organizations. And one of the challenges is, so organizations like First Movers International, which is a standalone peer, governed peer run and peer provider, we're not we don't bill Medicaid directly. We're not a clinical setting, so we wouldn't have anyone to sign off on a clinical, on a medical necessity, for example. The requirement under DCO is that we have an ability to exchange clinical information. We don't produce clinical information. So one of the things that I know there's a conversation with CMS around peer services being non-clinical but in clinical settings. And how do we meet the requirements without having to change who we are and our scope of practice? And one of the things I'm wondering is, in the conversations we're having here in Texas, is there any consideration?
That is a good question, and I can't answer that because I don't know about that. But that is a really good question. There are similar issues, I will tell you.
Oh, there are similar, ooh, I just got flagged. Yeah, so that's a good question. I did not know that. But it's also very similar to what we have with school mental health services. It's a very similar thing, and we're having issues there as well.
I have a question about one of the slides with Atlas.
Yeah.
You said that it was used as just kind of a measure, so it asks us 3 questions. But
There's
then-
actually 20, but I gave you like the overview.
Oh, okay. I
Yeah.
was just wondering about the acronym of connecting the interoperable systems with the client health outcomes. I was curious about the health outcomes for clients.
It's not about outcomes. Right now, it's just about, are you connecting?
Are there plans for it to be about client health outcomes? I'm just curious why it's titled that way as well.
Okay, so this is part of two larger, so behavioral health and hospitals have Atlas as a segment of the supplemental payment program. So it's just one piece, it's not the other measures. And the other measures would have some of that. But this is a new add-on twist. And we love a good twist in a story in Texas.
So I look through the judicial lens.
Yay,
on
bring
all
it.
these issues. And I will tell you that each county has their own technology, and they do not share court data, case data, any data whatsoever. And there's a big push right now, so continuity of care of people in custody and getting services in custody. And I know, people on the ground are fighting with their LMHA just to get like, have you seen this person before? I have all these,
Yes.
I have the code, tell me information.
Yes.
I mean, it would be brilliant to be able to link the information here from the LMHA into the jail liaison.
Can you be my new best friend?
We can be best friends, yes.
All right.
And I know that OCA right now is working on the connectivity of the counties
Right.
and getting that county data, but if both sets are moving at the same time,
Somebody needs to be making sure we're all on the same page. 100% agree. 100% agree. So let's make an agreement. I'm going to try to work on my piece. You try to work on your piece, and let's stay together.
okay. It's probably like an offline conversation, but do you know if like
I do not.
CHA or anyone is
You know what?
in with the judicial council?
That's a good question. I should ask Steve Wallop about that. I will ask him about that.
I just would say, this conversation's been going on also for many years, one being,
Come on, y'all knew everybody gets a dog.
at one point, there was the belief that it would be helpful if peace officers in their unit, when they got somebody's name, they could look up and see if they had a mental health record.
Right.
And that raised some major concerns. One being, if you're not in the public system, you're not going to be in that system. So you're discriminating against people who don't have access to any other services and those who have access to private services. So there's all kinds of things that come up with that.
Yeah.
One of the things that I think, I get what you're saying, because I think the jails need to know to build continuity of care. But I also think there is a concern that there be safeguards, because we require jails to be some of the biggest inpatient treatment programs in the state. But at the same time, you combine the intersectionality of incarceration with a mental health diagnosis, and that information can destroy somebody's life.
Again, I think that would have to. Again. I think that would have to do with the segmentation and how the segmentation works.
Yeah, 100%. I mean, data shows that if you were flagged with a mental health issue in a jail, you're gonna stay in jail longer.
Absolutely.
And again, technically, per national standards, nothing should be going in here except health information, and it shouldn't matter, right? Technically, in a perfect world.
Have you heard of any interest, maybe from the legislature or otherwise, of tracking similar kind of EMRs statistics for mental health in school?
So, schools, I know a lot about this. One of the issues that we have historically is the FERPA-HIPAA issue, right? And so for those of you who don't know, HIPAA is your privacy on the healthcare side. FERPA is your privacy on the school side. FERPA is much more strict than HIPAA, and that's where we have some of our issues with the school. We do provide school mental health services, by the way. And what we do, and I don't know that other schools do this or other school districts, but in San Antonio, what we do is to not have the issue with FERPA and HIPAA, we provide the service, they refer, we provide the services, and then it's in our purview, and it's our data, and then it's in our EMR, and then it goes here. So I can't speak for anybody else, but it is a conversation that we should be having. I know we work a lot on school mental health. Are you going to the youth one later? Then that's also a good question to ask in that one too, because they'll be talking a lot about schools.
Yeah, so obviously EMRs are in the physical health side, they're, so they're not without a few falls, you know, like builder saturation.
100%.
Yeah.
The technology person in me has to remind my providers that all the time.
Exactly, yeah. I guess my
Yeah.
question is, in, you know, behavioral settings, with the EMR usage there, are there any other like wrinkles that are still needing to be ironed out that are similar to what's happening with physical science?
So what I will tell you, and my doctors 100% would not agree with this statement, but behavioral health technology is not that complicated. We don't have to put in a lot of the stuff that you think about the physical health and all the nuances, and the behavioral health is just not that complicated. The EMR itself is a pretty small footprint for me to maintain for the hospital. So I would say probably not in relation to physical health, if that's the root of the question that you're asking. I will tell you, we do have, I would say probably my biggest headache in the technology is because not only do we have issues with purchasing and implementing it, I have a team of 7 in my health information technology department, 4 of which are IT, and actually now 4 are in health information that help me to manage everything, right? So I have to outsource quite a bit. That's also expensive. So you're talking about the cost of the implementation, where possibly on the medical side, there's a little bit more to that because there's so many more of them that, you know, on the bigger systems, they have resources and they have people that can do it. If I told you what the name of my EMR is, you'd probably never heard of it, and yet it's the one that's in all the local mental health authorities in the state, right? Whenever I fill out a form, it's like, which EMR do you have? Here's 10, and I'm always other. So I would say there's, you know, some of that, but I would say from a physical technology thing, we don't have a whole lot of issues. Good question, though.
This is more of a comment. To your point, one of the things that I just discovered in my work is that if you're a foster youth, and this is technology related, but if you're a foster youth that's incarcerated on your 18th birthday, you lose your health care, Medicaid. And when you re-enroll after you've been released, you're only eligible up until you're 21, as opposed to 26, just because of that incident with the criminal justice system. And so that's something that has just been brought to my attention, but it is a technology thing because they're being suspended and terminated within the system through HHS, and then when they try to re-enroll, it's the only option available.
And I know there's been a lot of work done on that too. Are you going to the youth group today? Okay, because that would be a good question for them, because there has been a lot of work done on that.
Yeah.
Right, Clayton? We're working on that.
We've also heard kind of on the other end of things, like from a lot of families about, you know, well, this is the current system. You know, my family member keeps going from, you know, hospital to institution to provider. And these providers, because sometimes it's like lack of capacity or lack of information, they're not seeing the full picture, and so sometimes they inappropriately address or treat, you know, individuals. And so one of the things we've been trying to work on is better understand, like, and do some HIPAA clarification on what is and is not accepted, so that these providers feel like they can take that information from families and other ones that do have kind of a more full picture while we're kind of making these steps toward building out the.
And that's a great point. Somewhat related, but to this, so I am the HIPAA officer for Clarity, and it's really amazing the confusion of what HIPAA actually is. Mental health information can be shared and shared openly, just like physical health. Substance use disorder has protections, but mental health is it's considered the same, especially in the interoperable mode. And if you're sharing it with another healthcare provider, that is explicitly protected in HIPAA. So there is a lot of confusion about the rule. 100% undersharing. Okay, I think I'm about at my time. Come on now, tech is fun. You guys are gonna go tell Seth, because let me tell you, for years, Seth goes, oh, Chris is gonna talk about technology in our meeting again, I knew it.
There's one thing, Chris, if you have time to talk about. So, COVID impacted
Correct, 100%.
how we perceive tech in access to care and providing.
Wouldn't interoperability been great during COVID?
So, yeah, but at what point do we also look at not only, electronic health records, but access to tech to serve our rural areas?
Yep.
Access to tech,
Yep.
we're a very small organization.
Yep.
And we have four, we're in Plano, Houston, McAllen, we do bilingual work there, and then in San Antonio.
Yep.
We have 4 staff. So a lot of that is done through Zoom and other things. How can we scale up things that work, but may not have the ability to, have.
The bottom line is that on the telehealth, Allison talked about, we had the telehealth group first, and we did a lot of work on that. So the one thing I would caution everybody in this room, because everybody hears me talk about this and say this ad nauseum, technology is expensive, even if you're doing it, but it's still cheaper than planting 8 doctors in BF somewhere, Texas, right? All of that being said, telehealth and those kinds of things and televisits are not the be-all, end-all, because guess what? No, but guess what? You know why? We still have a workforce capacity problem, right? And so anything fixes geography. It does not fix capacity. So I always say these things are like a stool, right? Like we got to fix reimbursement in order to get more people, and we need more people in order to do more stuff. And Texas is so wide and varied that technology could fix all of this, but we have to fix it all together because one is not the bullet for the other.
Not replace the fact that we don't have people.
Correct.
But having one isolated peer support specialist in very rural West Texas, which is still, considered a frontier.
Yeah.
Without support.
Right.
Doesn't work.
100%. 100%.
Those are the challenges. Growing a workforce that is supported as they continue to do the work in places where they do.
And I think we're getting better at that but also we're also stuck by broadband, right? So again, go back to this simple stick figure. We're in the 40s starting the telephone system all over again. So that's kind of where we're at. All right, you guys, I'm not kidding. Tell Seth this was fantastic. Thank y'all.